the current concepts in the management of a female with the recurrent pregnancy loss. I would like to clarify that I am a retired associate professor of Madurai Medical College. I'm not working at present. So first, we'll see the definition. Recurrent pregnancy loss is loss of 2 or more pregnancies, which excludes ectopic pregnancy and molar pregnancy. A pregnancy loss or miscarriage is defined as the spontaneous demise of a pregnancy before the fetus reaches viability. Therefore, it includes all pregnancy losses from conception until 24 weeks of gestation. Here, the woman is emotionally traumatic, similar to stillbirth or neonatal death. It may be, can you mute others? Somebody is talking, there is disturbance. Mute. It may be divided into primary, secondary, and tertiary. The primary refers to multiple losses with no previous viable infants. And the secondary is multiple losses in a woman who has already a pregnancy beyond 24 weeks of gestation. And tertiary applies to multiple pregnancy losses between normal pregnancies. Primary recurrent pregnancy loss as RPL without previous ongoing pregnancy, that is viable pregnancy beyond 24 weeks, as I already told. And secondary, when 1 or more pregnancy has progressed beyond 24 weeks, and pregnancy is confirmed at least by either a serum beta-HCG or a urine beta-HCG, and non-visualized pregnancy losses. And the recurrent early pregnancy loss is loss of 2 or more pregnancies before 10 weeks of gestation. And we recommend the use of recurrent pregnancy loss to describe related pregnancy demise and to reserve recurrent miscarriage to describe cases where all pregnancy losses has been confirmed as intrauterine miscarriages. When we look into the epidemiology, it affects 1 to 2% of women of reproductive age, depending on definition used. At least 50% of whom we don't know the pathology. It is not obvious to identify the pathological cause for this. About 70% of women who have experienced 2 recurrent losses will conceive and carry on the pregnancy to term successfully. The risk of further miscarriage increases after each successive pregnancy loss, reaching about 40% after 3 consecutive pregnancy losses. Previous live birth does not prevent a woman experiencing recurrent miscarriage, and it worsens, increasing as the maternal age increases. The etiological factors of recurrent pregnancy losses, 40 to 50% is contributed by unexplained causes, non-APS or thrombophilus, and 2 to 5% is contributed by the genetic factors, 10 to 15% anatomical factors, and autoimmune factors contribute 20%, 0.5 to 5% is due to infections, and 70 to 20% are due to endocrine factors. Female age and embryonic aneuploidy, that's a great relationship between these two. Spontaneous miscarriage occurs in 10 to 15% of clinically recognized pregnancies. Around 40% of miscarriages in recurrent miscarriage patients are chromosomally abnormal. There are major underlying causes, which are embryonic aneuploidy, meiotic chromosome segregation, errors in oocyte account for majority of embryonic aneuploidies. Miscarriage is strongly influenced by the female age. Risk of having 3 miscarriages for women less than 25 years is around 0.13%, but 100 times more likely if the age of the woman goes above 40. The risk factors for miscarriage in older women is largely untreatable. There is also, this chart shows the percentage of miscarriages which has an association with the age of the mother. That is, when the age is 20 to 24, it is 11%. Between 25 to 29, it is 12%. And between 30 to 34 it is 15%, and 35 to 39 25%, 40 to 44 51%. Karyotyping of subsequent miscarriages using whole genome approaches is therefore informative. Significantly, the likelihood of there being a parental cause is heavily influenced by whether embryonic aneuploidy is present, approximating 85% of patients with euploid miscarriage tissue were found to have an abnormality following recurrent miscarriage workup in one study. In unexplained recurrent miscarriages, embryonic aneuploidy screening out aneuploid embryos using in vitro fertilization in combination with pre-implantation genetic testing would improve the outcomes. However, at present, there are lack of randomized control trials investigating whether the PGT for aneuploidy screening is superior to expected management of RM patients. Recent retrospective data suggests that the pre-implantation genetic testing does not increase the live birth rates or shorten the time to pregnancy in this population. The recently published ESTEEM trial, there is a SHRE study into the evaluation of oocyte euploidy by microarray analysis that evaluated polar body, PGTA, for advanced maternal age, excluded the recurrent miscarriage patients, but found a reduction in the miscarriage rates in the PGTA arm. The parental structural chromosomal abnormality contributes 2 to 5% for the recurrent miscarriages, and it is compared to 0.7% of the general population. This structural chromosomal abnormality is around 85%, and balanced translocation, that is reciprocal translocations, is around 60%. The Robertsonian translocation contributes 40%. Parental karyotyping is recommended by the American Society of Reproductive Medicine guidelines and the German, Austrian, and Swiss OG societies. The RCOG proposed selective karyotyping depending on whether an unbalanced arrangement is found in the products of conception. Patients with chromosomal abnormalities should be referred for genetic counseling. That's a must. Pre-implantation genetic testing is not routinely advised since the likelihood of a pregnancy with an unbalanced karyotype surviving into the second trimester is very low, around 0.8% in one study, and overall live birth rates have not been shown to be higher with IVF or PGT compared with natural conception. However, PGT in couples with structural chromosomal defects might reduce the number of miscarriages experienced prior to a successful live birth, but this requires further evaluation. So there is, this was a prevalence of abnormal results in recurrent miscarriages, where the miscarriages were more than 3 consecutive pregnancy losses. The contribution by the parental chromosomal abnormality in around 492 patients was ranging to 5.5%, and the uterine structural defects was around 17.6%. Lupus anticoagulant was found in 2.5%, and anticoagulopin antibodies in 14.7%. Here, this shows that the uterine structural defects tops first, that is around 17.6%. Antiphospholipid syndrome is found in 5 to 20% of women with recurrent miscarriages, considered the most important treatable cause. And the diagnosis of APS requires 2 components. One is the adverse pregnancy outcome, and the second one is the antiphospholipid antibody detection. That is lupus anticoagulant LA or anticoagulopin antibodies ACL and anti-beta-2 glycoprotein 1 antibodies. Antiphospholipid antibodies impair pregnancy by various mechanisms. It inhibits the trophoblastic function, and it causes thrombosis of the uteroplacental vasculature, and there is initiation of local inflammatory response at the maternal fetal interface. So how to diagnose it? It requires moderate to high titers of anticoagulopin antibody or high titers of anti-beta 2 glycoprotein 1 on two separate occasions at least 12 weeks apart. Adverse pregnancy outcome refers to either more than 3 consecutive miscarriages below 10 weeks of gestation when other causes for miscarriages are excluded, and 1 or 2 losses of a normally found fetus when the gestation has crossed more than 10 weeks. And the APS, how do you treat that? With unfractionated heparin twice daily from positive pregnancy test until at least 6 weeks postpartum. And we can use low dose aspirin daily, commencing prior to pregnancy until 34 weeks. Low molecular weight heparin has the benefits of once daily administration and a superior safety profile for thrombocytopenia and osteopenia occurring in mother, but it is a bit costlier. Studies suggest that such patients could possibly benefit from low molecular weight heparin plus low dose aspirin, but this requires testing in large prospective trials. 19.5% are contributed by the uterine structural abnormalities, which may be congenital or acquired. Congenital contributes to 6.2%, like septate uterus, bicornuate, unicornuate, didelphus, and arcuate uterus. And acquired causes may be contributing 13.3%, which is fibroids, polyps, adenomyosis, endometriosis, and adhesions intrauterine as well as extrauterine. As assessment of uterine anatomy is therefore recommended for patients with recurrent miscarriages. 2D ultrasonography with or without saline infusion, that is sonohysterography, usually constitutes first-line investigations. The Thessaloniki ESHRE, that is the European Society of Human Reproduction and Embryology, and ESGE, European Society of Gastroendoscopy Consensus Group, recommended 3D ultrasonography for investigating uterine anomalies in high-risk patients. And when the diagnosis is suspected to be complex, or the malformations are more, or the diagnostic there is diagnostic difficulties, we can recommend MRI and endoscopic examinations. The commonest congenital abnormality identified in around 5% of RM women is uterine septate. Since the change from abdominal to hysteroscopic surgical approaches, uterine septae have become amenable to low-risk surgical correction. Pooled analysis of 14 studies involving 1,324 women undergoing hysteroscopic resection identified 15 perforations, that is 1.1%, and 2 cervical lacerations of 0.1%, which contributes 0.1%. The studies consistently report lower miscarriages rates in patients with metroplasty compared with untreated patients. Miscarriage decreased from 41.7% to 11.9% following hysteroscopic septal resection. In another study involving 361 patients, the miscarriage rate decreased from 94.3% to 16.1%, and the live birth rate increased from 2.4% to 75% following hysteroscopic correction. See how there is a remarkable improvement in after correcting the septate. In this recent guidelines for managing uterine septate, they recommended that it is reasonable to consider septum excision, a view supported by the German, Austrian, and the Swiss OG societies. This is septal resection that was done in a 33-year-old patient who had no live births and 2 spontaneous abortions, one at 11 weeks and one at 8 to 9 weeks of gestation, after visualizing the fetal heartbeats. And the ultrasound of the septate and the hysteroscopic view of the septate is seen in picture A, and the fundal fundus examination by laparoscopy seen in B, and C and D shows the post-resection view of the uterine cavity. We could also notice the cutting knife electrode, that is the Collins electrode of a resectoscope. Now we'll move on to fibroids and other acquired structural defects. Systematic review found an association between fibroids and higher miscarriage rates. However, robust prospective evidence that myomectomy reduces miscarriage is lacking. Widely acknowledged that the magnitude of effect of fibroids on pregnancy is greatest for submucous, least for subserous, and intermediate for intramural fibroids. A recent systematic review identified only one ORCT involving the hysteroscopic resection of submucous fibroids. Miscarriage rates were 38.5% in myomectomy group versus 50% in the expectant management group. So this shows that when you remove the submucous fibroids, the miscarriage rate drops down. One paper investigated the impact of submucous fibroids specifically in the context of recurrent miscarriages patients. Among 966 RM patients, the incidence of all fibroid types was 8.2%, that is 79 out of 966. And similar to values found in another series of RM patients where it was 58 for 904, contributing 6.4%. Following hysteroscopic fibroid resection in 25 of 79 cases with cavity distortion, the mid-trimester loss decreased significantly from 21.7% to 0%, while their live birth rate doubled from 23.3 to 52%. So there is also a lack of evidence regarding management of polyps and intrauterine adhesions in patients with recurrent miscarriages. However, since many clinicians elect to remove the cavity distorting lesions on the basis that they could possibly impair implantation, and this is a difficult area in which to conduct the randomized control trials. Until better quality evidence emerges, the ASRM, American Society of Reproductive Medicine guidelines, and the German, Austrian, and Swiss OG societies proposes that it is reasonable to undertake surgical correction in cases of uterine cavity defects associated with fibroids, polyps, and adhesions. Now we will move on to the inherited thrombophilias, which refers to an increased risk of developing venous thromboembolism and can be acquired APS or inherited. The inherited thrombophilias include factor V Leiden mutation, prothrombin gene mutation, protein C deficiency, protein S deficiency, and antithrombin deficiency. Earlier associations between the inherited thrombophilia and recurrent fetal loss have not been confirmed in subsequent prospective analysis, and a very recent review found no evidence that thromboprophylaxis improves the pregnancy outcome. For the present, it is not recommended that RM patients be routinely screened for thrombophilia unless otherwise indicated due to prior vascular thromboembolism, or be given antithrombotic prophylaxis even if a thrombophilic defect is found. Moreover, a meta-analysis of 8 trials involving 483 patients with previous late, that is more than 10 weeks of pregnancy or recurrent early losses, found no benefit with the low molecular heparin. A Cochrane review of 9 studies involving 1,228 women with a history of at least 2 unexplained miscarriages with or without thrombophilia also found no improvements with the low dose aspirin and low molecular heparin or a combination of both. The organizing ALIFE2, that is anticoagulants for living fetus 2, randomized control trial will hopefully clarify guidance on low molecular heparin use with inherited thrombophilia in future. While miscarriage is increased with overt hypothyroidism, the association between the subclinical hypothyroidism and the pregnancy loss is less clear. So using an upper limit of 4 to 5 milli-internationals per liter of thyroid stimulating hormone, the prevalence of subclinical hypothyroidism in women of reproductive age group is around 4 to 8%. Pre-pregnancy TSH value of 2.5 milli per liter found no association with increased miscarriage. A recent large prospective cohort study involving 5,405 pregnant women with subchorionic hematoma, thyroxine replacement was associated with reduced miscarriage only in those with TSH which was more than 4 milliliters unit per liter, and not if the TSH was ranging between 2.5 and 4 milliliters units per liter. There are no RCTs examining the impact of thyroxine in RM women with the subclinical hypothyroidism. Thus, there is a lack of evidence that subclinical hypothyroidism diagnosed at a lower threshold of TSH, that is more than 2.5 milliliters per liter, predisposes to miscarriage in RM patients, or that the thyroxine improves outcomes. Data from non-RM patients do suggest that for the subclinical hypothyroidism diagnosed at TSH of more than 4 milliliters per liter, thyroxine treatment could be beneficial. Current recommendations therefore support thyroxine for TSH more than 4 milliliters per liter, but not at TSH of 2.5 to 4 milliliters in the absence of thyroid antibodies. But when there are thyroid antibodies, we have to treat even if the TSH is ranging between 2.5 to 4 milliliters international units. So consistent with this, the American Thyroid Association now advises using TSH if it is more than 4 milliliters per liter. Another uncertainty pertains to antibody to thyroid peroxidase, TPOA, and or thyroglobulin, which is present in approximately 14% of reproductively aged women and has been associated with increased miscarriage risk. However, notably, miscarriage risk may be exacerbated when thyroid autoimmunity coexists with the subclinical hypothyroidism. Subsequently, the American Thyroid Association gives a strong recommendation for thyroxine use with combined autoimmunity and the TSH of more than 4 million international units per liter, and a weak recommendation to consider thyroxine with autoimmunity and TSH more than 2.5 million international units per liter. But now that we all know that for the first trimester, the TSH should be less than 2.5 million international units per liter, and for the second trimester of pregnancy also it should be less than 2.5, and for the third trimester it should be less than 3 million international units per liter. Now we'll see the association between PCOS and recurrent pregnancy losses. Although polycystic ovarian syndrome has been associated with increased miscarriage risk related to the hyperinsulinemia and hyperandrogenemia, there is a lack of clear evidence that PCOS predisposes to recurrent miscarriages. Meta-analysis found that metformin, an insulin sensitizing drug often used in PCOS patients, did not reduce the miscarriage in PCOS. A single small randomized control trial of 46 women considered of low quality found that bromocriptine treatment in RM patients with hyperprolactinemia significantly reduced the miscarriage rates. But larger trials are needed to clarify the potential benefit of dopamine agonist in RM patients with idiopathic hyperprolactinemia. Now we'll move on to the immunological factors and the progesterone supplementation. In over half of RM couples, all tests on the parents are normal. In a recent prospective study, no abnormalities were identified in 55% of couples after strict application of the American Society of Reproductive Medicine guidelines. Given the critical role of immunological and inflammatory changes in implantation and the importance of progesterone for inducing secretory endometrial changes and possibly promoting a favorable inflammatory milieu, there has been intense interest in immunomodulation and progesterone supplementation for these patients. Glucocorticoid produced inconsistent results in RM patients and can increase the risk of prematurity, orofacial clefts, gestational diabetes, and hypertension. These are the side effects of using glucocorticoids. Two recent meta-analyses of using IV immunoglobulin and use in RM patients found no evidence of improvement in the live birth rates. Recent meta-analysis of allogenic lymphocyte immunotherapy, example, the paternal lymphocyte infusion, reported improved live birth rates in treatment arm. However, these studies have been criticized for their low quality, low numbers of patients. Finally, the available evidence from RCTs does not support the use of heparin and low-dose aspirin either alone or in combination. So transfusion of blood products may also bring serious complications, and that long-term heparin use will also have the risk of maternal osteopenia. I will move on to the intralipid. It's a fat emulsion used for parenteral nutrition. It has been proposed that intralipid might benefit the RM patients by reducing the peripheral blood natural killer cells activity and suppressing the pro-inflammatory cytokines. Intralipid has been evaluated in only one RCT that tested whether a 250 ml infusion on the day of oocyte retrieval with further infusions if there was a positive pregnancy test would increase chemical pregnancy rates in recurrent miscarriage patients with elevated peripheral blood natural killer cells of more than 12% undergoing IVF. No benefit was found for the primary outcome, chemical pregnancy, although increased rates of ongoing pregnancies and live birth rates were observed, the significance of which requires further investigations by appropriately powered studies. Tumor necrotizing factor is a pro-inflammatory cytokine produced by the T helper cell 1 and can be neutralized using anti-tumor necrotizing factor alpha drugs such as the adalimumab, that is Humira. One small retrospective study found improved live birth rates when anti-TNFA alpha was combined with other regimens that included heparin, low-dose aspirin, and or IV immunoglobulin. However, no well-defined prospective studies of anti-tumor necrotizing factor alpha use in RM patients is well established. Now we'll move on to the granulocyte colony stimulating factor, which is a cytokine produced by residual cells that stimulates the granulocyte proliferation and differentiation. There was one small RCT on 68 women with unexplained RM found that the GCSF treatment administered subcutaneously from the 6th day after ovulation to the 9th week of gestation increased the live birth rates from 48% in the placebo group to 83% in the treated group. More recently, a pilot randomized control trial found no benefit following intrauterine GCSF administration in unexplained RM patients. Progesterone. This is in recurrent miscarriages. PROMISE trial involved 836 women with idiopathic RM randomized to receive either 400 milligram of vaginal micronized progesterone twice daily or a placebo from the time of positive pregnancy test to 12 weeks of gestation. There was no difference between the two groups miscarriages or live birth rates. In contrast to another randomized control trial involving 700 women, also tested whether the same dose of vaginal administration of natural progesterone would benefit unexplained RM patients. But unlike the PROMISE trial, this trial commenced treatment in the luteal phase immediately after documenting the ovulation either by ultrasound or using the LH kit, and continued the progesterone until 28 weeks of gestation. So in this study, they start from the luteal phase and they were giving progesterone up to 28 weeks of gestation. And this Egyptian trial found significantly lower miscarriage rates, that is 12.4 versus 23.3%, and higher live birth rates, 92% versus 77 in the treated group. A meta-analysis of 10 RCTs, including the PROMISE trial involving 1,586 women with idiopathic RM, evaluated the effect of natural and synthetic progesterones administered during the first trimester and commenced after pregnancy confirmation. Lower miscarriage and higher live birth rates were found in the 8 studies that used synthetic progestogens. However, included studies spanned more than 60 years and multiple formulations, dosages, administration routes were used, making it difficult to recommend any particular regime of progesterone. Collectively, these data suggest that progesterone is likely to be beneficial in an unexplained RM. Synthetic progesterone may be superior to natural progesterone, at least when progesterone is commenced after a positive pregnancy test. However, formulation, dosage, and route of administration are to be defined. Natural progesterone may be beneficial, but should be started in the luteal phase itself, with consideration given to continuing beyond the first trimester up to 28 or 34 weeks. So what are the other factors? The psychological support in a dedicated RM clinic setting, complemented with weekly ultrasound scanning, so-called the tender loving care, is beneficial. Vaginal bacterial vaginosis is associated with the second trimester miscarriage, but prospective evidence linking bacterial vaginosis or other infective agents with the recurrent early pregnancy loss is lacking. Latent genital tuberculosis and subclinical endometritis and sexually transmitted diseases like chlamydia, syphilis, and HIV, all these should be treated. Patients should be advised that modifiable factors such as obesity, coffee intake, alcohol, smoking, and cocaine use have been linked with increased miscarriage risk. Increased semen abnormalities like DNA fragmentation and aneuploidy have been found in RM couples, but at this stage, such abnormalities cannot be considered predictive of an increased risk of recurrent miscarriages. So how do we assess the prognosis? We have to take into account the number of miscarriages. If it's 2 to 3, it is good prognosis. 4 contributes to medium prognosis. And if it's more than 5, it is poor prognosis. And the age, when the patient are in 20s, it is good. 30s, medium, and more than 40s or around 40, it is poor prognosis. And karyotype of abortus, if it is aberrant, it is good prognosis. And if it is normal, it is medium prognosis or poor prognosis. And primary or secondary abortus, secondary is good prognosis. Primary and secondary or medium or poor prognosis. And if it is combined with infertility, it is poor prognosis. And if the natural killer cells are normal, it is good prognosis. If it is high, it is poor prognosis. So this is the algorithm of treatment of poor prognostic patients with the recurrent miscarriages after initial management and further miscarriages. If it is divided into 2 groups: those who are having miscarriages in the first trimester and those in late trimester. And if it is a first trimester loss, we have to go for IV immunoglobulin even without immune testing. Hormone supplementation has probably been used previously. And you have to submit both the products of conception for genetic assessment. And if it's euploid, it has we have to proceed in the above mentioned treatment. And if it is aneuploid, then if the loss is late also, we have to think of hereditary thrombophilia, where we can use anticoagulants. If there is increased natural killer cells, we have to go for immunoglobulin IG. If there is placental ileitis, steroids may be considered. And if aneuploidy, you have to parenteral karyotyping is a must. If aberration and embryonic aneuploidy is found, then pre-implantation genetic screening is also essential. If sporadic aneuploidy, consider repeating the initial treatment. Now, I like to share some of my tackling such patients. Patient A, she is 27 years old with a regular menstrual cycle. She was married for 7 years and had a recurrent pregnancy loss 5 times. The first was a spontaneous abortion in 2010, and second one was 24 weeks. Fetus died due to hypoplastic lung. The third one was in 2014, where she had miscarriages at 8th week of gestation. And fourth one, at 15 weeks of gestation, she ruptured her membranes. And the fifth one in 2016, it was a spontaneous abortion at 70 days. We tried IUI once, but it failed. But the patient had a natural conception, and patient was admitted to the hospital at 6th week of pregnancy. These are all the investigation findings. And she was put on a low molecular weight heparin, 20 units daily, and HCG 5,000 units weekly once, and tablet dufaston 10 milligram 3 times a day, that is dydrogesterone 10 milligram 3 times a day, vaginal progesterone 400 milligram 3 times a day up to 3 months. We did a cerclage at 12th week of gestation after measuring the nuchal thickness and doing double screening and ruling out anomalies. And the vaginal progesterone, after cerclage, vaginal progesterone 400 milligram 3 times a day, and the Prolutone depot was given 500 milligram weekly once. She had the injection Dodilon 3 times a day, followed soon after cerclage, and then it was switched over to Dodilon Retod 40 milligram HS with tender loving care. And patient carried her pregnancy was carried up to 35 weeks when she developed labor pains, underwent LSCS, delivered a live preterm of 2.2 kg male baby, mother and baby discharged in good condition. The second one was, she was 42 years. She had 3 recurrent pregnancy losses, and she was married for 13 years. The first one was, she conceived by the 5th year of her marriage in 2010, 41 days missed abortion. And in 2012, 70 days spontaneous abortion. 2015, she had a missed abortion at 40th day. But she had a natural conception, admitted in hospital at 10th week of gestation, and underwent cervical cerclage at 12 weeks of gestation after ruling out congenital anomalies. And patient was on progesterone support up to 34 weeks of gestation, along with aspirin, low dose aspirin, and tablet Dodilon 40 milligram HS with tender loving care. Injection betnazole, cortisone, was given at 12 milligram dose, 2 doses 24 hours apart for lung maturity at 30th week of gestation. She underwent LSCS at 35 weeks of gestation after developing pain, and delivered a female baby as breech, and the baby weighed 2.1 kg. Mother and baby discharged in good condition. And the third case was 26 years with regular periods. She had 4 pregnancies, 1 live birth, and 2 abortions. The first was an abortion, 3 months missed abortion, and she had a live full-term normal delivery at 36 weeks with progesterone support. And the second, the baby was alive and well. The third was 5th month, she had abortion, twin gestation, a spontaneous abortion. So this is a case of tertiary type of miscarriage. Patient had natural conception, admitted at 3rd month of gestation, had cervical cerclage. Patient was on progesterone support up to 34 weeks. Patient landed with preterm labor at 35 weeks. The cerclage stitches were removed, and she was allowed for a vaginal delivery. She had a male baby, both mother and baby discharged in good condition. And the fourth case, she was 38 years, she had regular cycles and married since 10 years. She conceived in the 1st year of marriage in 2008, but she had a missed abortion at 58th day. And Second abortion was third month of pregnancy. It was an IVF conception. She had a spontaneous abortion in 2011. And the third was in 2013. She had a missed abortion at 45th day. And patient had undergone IVF 6 times elsewhere with no success. So we did IVF in our hospital and she had a positive pregnancy. She was hospitalized till delivery. Hormonal support given as per our protocol for IVF patients. At 12 weeks of gestation, had an elective cervical cerclage after ruling out congenital anomalies. Patient had a severe PH and the baby was an IUGR weighing only 1.8 kg. So we did an elective LSCS at 35 weeks of gestation for impending eclampsia. Baby and mother discharged on the third day of LSCS, but they were in good condition to a higher center for neonatal care. So to summarize the current evidence regarding recurrent miscarriage, if it is an antiphospholipid syndrome, we have to support by unfractionated heparin, low dose aspirin. But it needs further investigations to use the low molecular heparin and non-criteria APS. Uterine septate definitely have to do a hysteroscopic resection, but the RCT evidence is awaited. And submucous fibroids, polyps, and adhesions has to be tackled hysteroscopically, and we need RCT evidence awaited. The results are awaited. Structural chromosomal rearrangements, genetic counseling is very important. And thyroid function, we have to treat when the TSH is more than 4 million international units. But if it is ranging between 2.5 to 4, with the antithyroid antibodies, we have to definitely treat such patients. Inherited thrombophilia, screening is not recommended. Unexplained recurrent miscarriages, treatment of immune factors is not recommended. A lack of standardized diagnostic criteria for specific immunological conditions. Progesterone is likely to be beneficial, and antioxidants are used to reduce the stress. Then embryonic chromosomal abnormalities, karyotyping of products of conception is very informative and it's a must, and provides a strong indication of likelihood of finding a parental abnormality and helpful in providing an explanation for the couples. So the lack of evidence that IVF with PGT increases chances of live birth still exists. Psychological support, tender loving care is very, very essential, and patients find dedicated RM clinics with regular ultrasound scanning. That is very helpful. And to summarize, essential investigations, that is measurement of lupus anticoagulant, anticoagulopin antibodies, thyroid function, transvaginal pelvic ultrasonography. The key treatments to consider are the first trimester progesterone administration, levothyroxine in women with subclinical hypothyroidism, and combination of aspirin, heparin, or low molecular heparin in women with antiphospholipid antibodies. Appropriate screening and care for mental health issues and future obstetric risk, example, preterm birth, growth retardation, stillbirth, will need to be incorporated into the care pathway for couples with a history of recurrent miscarriage. We suggest healthcare services structure care using a graded model in which women are offered online healthcare advice and support, care in a nurse or midwifery-led clinic, and care in a medical consultant-led clinic is a must. And patients with chromosomal abnormalities should have genetic counseling. So to conclude, recurrent pregnancy loss is a devastating outcome for patients and their clinicians. It continues to be a clinical dilemma. What is frustrating for couple and challenging for the clinician are the varied etiological factors, the exhaustive workup, and often no answers at the end. The causes like anatomical problems, endocrinal, infection, and immunological factors like antiphospholipid syndrome and genetic causes, which are equally perplexing. and hematological causes leading to poor circulation in developing gestational sac may be a major contributory factor resulting in fetal demise. In spite of extensive research, the concept of fetal allograft rejection by mother remains an unproven enigma. This reminds me of one of my patients. She was a medical representative's wife. She had already 5 abortions at exactly when the 20th week begins. She came for the 6th one. She was given proper care, all medications, and I was insisting her to get admitted. She was just postponing the admission. I did a scan by just 3 days before 20 weeks, when the fetus was alive, moving, it was healthy. All the Doppler studies were all normal. Everything was normal. But she came on the onset of 20th week. And to my great grief, there was absence of fetal heart. So we sent the products of conception along with the fetus to Chennai to the Mediscan Dr. Suresh, and it showed only the placental pathology, but there was no congenital anomalies. But now I lost contact with her. I don't know what happened to her. So this allograft rejection by the mother is something which is very grieving. And this may be a process of natural selection which allows for survival of the fittest embryo, maybe. The new frontiers like use of granulocyte colony stimulating factor, IVF, lymphocyte immunotherapy, IV immunoglobulins, tumor necrotizing factor alpha, use of antioxidants, micronutrients, intralipid infusion, all paved way towards managing recurrent pregnancy losses. The trend recently is moving away from evidence-based medicine towards a more personalized approach, which accesses the individual needs and helps to design their treatment. The role of positive support, methodical workup, reassurance, scans in the first trimester, and at length counseling in these patients will help them reach the goal of getting a live child. I usually do scans frequently and show them the beating hearts, which reassures them and have a help them to have a positive attitude and positive thinking. So before I conclude, I would like to quote from the Proverbs, that is, hope deferred makes the heart sick, but a longing fulfilled is a tree of life. Thank you so much for your patient listening. Questions are invited.
Yeah, any questions? Requesting to raise if any question is there. Yeah.
Yeah. What about the infectious etiology? Yeah. Point 5, I was mentioning, you have to treat tuberculosis, and if there is HIV or chlamydia, all these things to be treated. You have to take vaginal swabs, find out what's the cause for the recurrent infections, and you have to treat the cause accordingly. That is very important.
Okay. Okay. Hope the talk was very clear, and that is why there are no questions rather. So everything is very clear to the audience. And ma'am, thank you very much for delivering a wonderful talk. There were new learnings even for me as far as the recurrent pregnancy loss is concerned. Like you have touched upon different new things which I have come across today. So thank you very much for adding to my knowledge also. Thank you very much, ma'am.
Thank you so much for giving me this opportunity. And it's a really complicated subject. And the real enigma is that when we face the pregnancy losses, even in spite of treating them, that's a major thing.
Right.
But if they go with a baby, we and the patients are doubly happy to have a successfully treating a recurrent pregnancy loss patient.
True, ma'am.
Thank you
Yeah.
so much for giving me this
Thank you, ma'am.
opportunity. I thank the audiences also for listening to my talk. Thank you so much.
Yeah. There is one more question from Dr. Sindhuja. What are treatment options for ANA positive patient with RM?
Yeah, we can go for immunosuppressants or immunoglobulin therapy, or we can go for ANA means, that is, we can go for cortisone. But cortisone therapy early in pregnancy will lead on to all sorts of side effects like a cleft lip, cleft palate, so many things. So we have to choose between the devil and the deep sea. So yeah, we can pre-conceptionally we can treat it. When the ANAs have come down, then we can go for we can ask the patient to become pregnant.